Hi, I'm Dr. Lisa Bagnall from We Teach Nursing. Don't forget to join my Facebook page, We Teach Nursing, especially if you have any questions. Today we're going to talk about atrial dysrhythmias. The first one I want to talk to you about is normal sinus rhythm with premature atrial contractions, known as PACs. And just like all the other PowerPoints that I've shown you thus far, we want to use this algorithm to determine what our true rhythm is. First of all, we want to know if our rate is normal, slow, or fast. Most dysrhythmia strips on test equal a 6-second strip. So let's count our complexes. 1, 2, 3, 4, 5, 6, 7, 8, 9. Our heart rate is 90, and because it's between 60 and 100, we would define that as a normal heart rate. Is the rhythm regular or irregular? Well, in this case, you're not going to have to take your calipers or use a piece of paper and mark the top of your complexes on that piece of paper and march it out to see that it is clearly irregular. These QRS complexes are not equidistant to one another, so we already know we have some sort of irregularity. Are there P waves? Yes, there are. Is there one for every QRS complex? Not necessarily. There's one for this one and for this one, and then we have a beat that's early and we really cannot see a definitive P wave. The same would be true for this complex here. For those that have a P wave, is the PR interval normal and does it stay the same throughout? So the PR interval is about, let's see, 1, 2, 3 boxes wide. That's 0.12 seconds. I'm going to look at another one. 1, 2, 3. It's 3 boxes wide there. So yes, it is normal for that of which we can see a P wave. Is it regular and normal? Yes. But for the complexes that come early, if you look in the T wave that precedes that complex, you will notice that it looks different than other T waves. And so we know that there is something buried within it. And it is most likely an atrial wave. With a premature atrial complex, PAC, the beat is initiated early, the QRS complex is narrow, and there is usually, not always, but usually a compensatory pause, which you will see here, a bit of a pause before the next beat. And the same is here, normal, 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 early, there's something buried within, that is an atrial wave. And this would be a definition of normal sinus rhythm with premature atrial contractions. Also, don't forget to look at the T wave. It's normal in those that we can see. Even in the early beat, you will see that the ST segment is normal, and the interval is also normal. It's less than 0.50. Paroxysmal atrial tachycardia is a common dysrhythmia seen most often in younger people. And it's just what it says. Paroxysmal means it begins and ends abruptly. It can also be continuous. Atrial tachycardia, or PAT, is also called PSVT. And they're interchangeable. It just means that whatever is happening in the atria or initiated in the atria, and it's happening above supra the ventricles. Ventricular. Supraventricular means above the ventricles. So, is the rate normal, slow, or fast? Well, it doesn't take a rocket scientist to look and see that this is fast. But let's actually count it. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. So we have 16, a heart rate of 160. However, you have to be careful with this particular formula in this case, because when it returns to normal sinus rhythm, you have a heart rate of about 75. Let's take a look at that. 300, 150, 100. I'm sorry, you have a heart rate of 100, not 75. So that would fit normal criteria. On this end, though, look at this. 300, 150. It's greater than 150 because it starts again right before this line. So that gives you a heart rate of around 180. So in the dysrhythmia portion of this rhythm strip, it is very fast. And with paroxysmal atrial tachycardia, or PSVT, it is not uncommon to get heart rates up to 220. I had a colleague of mine that I worked with in the CICU at an area hospital who drove herself in SVT with a heart rate of 220. Not the greatest decisions, but because she was young, she was able to sustain a very good blood pressure and was fairly asymptomatic. Now we're going to get into atrial flutter. Again, is this rate normal, slow, or fast? And with atrial flutter, it can be either regular or irregular. It can be normal, slow, or fast. So again, because dysrhythmias are treated dependent upon the stability of the patient, it's important to know if the rhythm or the rate is fast, slow, or normal. And in this case, we have 1, 2, 3, 4, 5, 6, 7 complexes in a 6-second strip. This would give you a heart rate of 70. So that's a normal heart rate. And in this case, is it regular or irregular? If we took our calibers or our piece of paper and did our marks and marched them out according to the QRS complexes, they would be equidistant from one another. In this particular case, it is normal and regular. However, there are times where you may have flutter waves that vary in between QRS complexes, and it may give you an irregular heart rate. That is also very common. Are there P waves? And there are no P waves. I don't see anything that's definitively looking like a P wave. But what we do have here is a sawtooth configuration. And if you count the number of flutter waves, 1, 2, 3, 4, you have 4 flutter waves in between these QRS complexes, and it's pretty consistent. This is atrial flutter 4-to-1, technically. Because the flutter waves are a little bit larger in the electrical signal, you really can't define your ST segment. Because we have this sawtooth configuration and we do not have a definitive P wave, we know, and because our QRS complexes are narrow, we know that this dysrhythmia is coming from above the ventricles, and that in this case, because of this sawtooth pattern, we have atrial flutter. Now, in my initial video, when I talked about determining heart rate using the 300, 150, 175 formula, this is where this formula becomes extremely valuable, because you can determine oftentimes the atrial rate by looking at the number of boxes between the top of this wave to the top of this wave. Atrial fibrillation has atrial rates that are greater than 350 and in some cases even greater than 600. You cannot count the atrial rate in atrial fib. It is always irregular. It is also the most common dysrhythmia, bar none. However, you still want to look at this formula to determine, to make sure that it's coming from above the ventricles, number one, and that your rate is such that it promotes good hemodynamics in your patient. So in this case, is this normal, slow, or fast? Well, let's take a look. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. It's a little fast, 110. Is it regular or irregular? And again, you really wouldn't need your calibers or that piece of paper to draw your tops of your QRS complexes on to tell you, just by looking at this, that this is an irregular rhythm. And just to let you know, atrial fib is always irregular. Are there P waves? Absolutely not. There is no P waves, or there are no P waves. Is the QRS complex narrow or wide? And this is important. In this case, it is narrow. It is less than 3 boxes in width. The T wave, the ST segment is really hard to see here, almost impossible, probably because the atrial electrical discharge is being overpowering that signal compared to looking at the T wave. And sometimes you will see it and sometimes you won't. This is classic atrial fibrillation. Now with atrial fibrillation and even with atrial flutter, there's always a risk for a pulmonary embolism or a blood clot in the deep veins of the legs. If it is witnessed, in other words, a patient was in sinus rhythm and then they went into atrial fibrillation, the goal of treatment, of course, is to get that patient back into sinus rhythm. If the patient comes into the emergency room or into the physician's office and they do an EKG and they find out, oh gosh, this is a new onset of atrial fibrillation, it is unwitnessed. The goal of treatment then is anticoagulation and keeping the heart rate under control. You will hear a term called atrial fib with RVR, which stands for rapid ventricular response, and that simply means that the atrial fibrillation heart rate is greater than 100. The goal of treatment when it's unwitnessed is to keep that heart rate less than 100 with more often than not a calcium channel blocker such as diltiazem IV or with metoprolol. Long-term treatment, if it becomes a problem, the AV node can actually be burned out and AV pacing can be placed for the patient. There are other procedures called the Maze procedure, which is a little more in-depth than what we're going to go into today in this dysrhythmia lecture. We will go into it a little bit more when I talk about treatments of all these dysrhythmias. One of the things that you will see in the literature and occasionally in your patients is a syndrome called Wolff-Parkinson-White syndrome. It's where there's an electrical pathway between the atria and the ventricles exists, and it causes a cyclic rhythm between that pathway and a tachycardia. And it's usually present at birth, and it is fairly rare. In other words, there's about 4 out of every 100,000 people have Wolff-Parkinson-White. It can happen or show up in people of all ages, but it can also be seen in infants. Most people with Wolff-Parkinson-White experience symptoms between the ages of 11 and 50. The treatment of it is to prevent these episodes, and a lot of times that area that has that electrical pathway has to be burned out by a procedure known as ablation. And that will permanently correct the heart rate, or the heart rhythm rather. The classic sign or clue of Wolff-Parkinson-White is this delta wave, which is seen at the beginning of the QRS complex, and it causes a shortening of the PR interval. Again, this is fairly rare, and it's not usually included in the dysrhythmia lectures. However, I felt that it was important to include it in this particular PowerPoint because you will see it quite often if you work, not often, but you will see it on the cardiac floor. Now, one thing I want to go over, and this is so critically important, is the concepts that are important to remember, and it's because I've seen people treat dysrhythmias without treating the patient first. Bear with me for a minute as I pull this up. Always remember that treatment depends upon the patient's clinical signs and symptoms and level of stability. Another thing that's important to remember is to always check your patient first. Don't just go by the EKG rhythm. There may be a lead disconnected, or the patient may be brushing his teeth, and it'll look like ventricular tachycardia when there's actually nothing wrong. So always check your patient first. It's also important to ascertain whether or not the patient is breathing, if they have a pulse. What are their vital signs? Is the blood pressure stable or unstable? Are there any other unusual signs and symptoms such as shortness of breath, diaphoresis or dizziness, or a little bit of pain, or just not feeling right? If you initiate the emergency response team or the code team, make sure that you pull up the chart, or if you call the physician. The worst thing that you can do is be that patient's primary nurse, have the team arrive or the doctor arrive, and you just have no idea the patient's history or their labs or their vital signs. It's important to have that information available, because what you tell them many oftentimes directs the treatment and can save that patient's life. Make sure that you have the emergency equipment available. That includes things like your suction canister. Make sure it's hooked up to suction. Make sure that the suction's actually working, and that you have the tubing, including the Yankauer suction to suction out the patient's mouth. Make sure that the patient has the ambu bag in the room, especially if there's any decompensation in the patient's status. Make sure if you bring the code card in the room, hook it up to the patient. Put the electrodes from that electrocardiograph machine, I can't even talk right, from the EKG machine to the patient, because you will not be able to cardiovert unless those leads, or even pace, unless the leads from the machine are hooked directly to the patient. If the patient needs CPR, make sure you have the bed in CPR mode or the backboard under the patient. Remember, early interventions such as defibrillation and CPR can save a patient's life. All the advanced life support measures in the world will not save that patient if basic life support measures are not in place. I once flew a patient from one facility to another. We just needed a quote-unquote simple pacemaker. The patient had an acute MI while we were in the air, and when we landed, my patient was in a full-blown cardiac arrest. We got the patient into the ambulance as soon as possible. All I could do, regardless of all the drugs that I had and the EKG machine and defibrillator, there were only 2 of us. All I could do was proper CPR. That was it. The patient survived, thank God. So, again, make sure that you remember these points, because, again, all the advanced interventions in the world will not work if you do not have your basic life support measures in place. That concludes this video.